Jenna Pruesker. I'm the pharmacist program coordinator for Nebraska ASAP, and I'll be co-presenting this presentation about tracking and reporting antibiotic use with Dan German, who is our project manager extraordinaire, Excel master, who created some really good tools to share with you today. And so we'll go ahead and get started here. Okay. So really what we want to do today in this session is talk a little bit about the core elements of tracking and reporting. Specifically, what should you be tracking? Should you be reporting and to whom? And then Dan will do a demonstration of the tool that we've created. And I think our hope and our goal is that either you take it and use it, or you take it and compare it to what you're currently using and see if there's any way you can improve upon what you're doing to make tracking and reporting more efficient for you when you leave here. So as a reminder from this morning, when we looked at the core elements of antibiotic stewardship, one of the core elements that was a little bit lower in long-term care facilities, both here in Nebraska and nationally, is reporting. And so we're hoping to provide you some guidance and some tools that we could potentially improve the reporting process a little bit in long-term care for antibiotic stewardship. So I'm sure you've seen this before, I know Dr. Ostroff had it in his presentation too, but part of the reason we do this is because of the CMS requirement. And tracking and reporting is really important here because they specifically say you need a system in place to monitor antibiotic use. And so that CMS requirement went in place in 2016, I believe. So we're coming up on 10 years. But right away, right after that went in place, the next 2 to 3 years afterwards, this was something that was really difficult for facilities to do. They didn't really provide a lot of guidance on how to track and report antibiotic use data. And you can see they very commonly cited facilities for the tracking and reporting components here. Of all of the antibiotic stewardship type citations that were written to nursing homes, 40% of them had to do with tracking and reporting. Their kind of details on that about what they were citing and why were for the tracking component, the logs didn't have enough information to allow analysis of whether the infections met criteria for starting a treatment or about the length of the treatment. And then on the reporting side, there was not documentation being done that the actions and the tracking and information was being communicated to the medical director or leadership at the nursing home. So again, this was only a couple years after that regulation went into place. And so I think we've made a lot of progress since then. As of 2022, 99% of nursing homes in the country reported that they do have a system in place for tracking and reporting antibiotic use. So I think this is, you can see right there how far that has come from many, many facilities getting cited for it in just a few years to nearly 100% of them having something in place. But what we do see is it really varies on how people do this. And what I want to point out here is that almost half of nursing homes are still doing manual antibiotic use tracking, whether that be in an Excel spreadsheet or on paper. Only about a third of them are using their EHR system, and we'll talk about that a little bit and why that is. And then around a quarter of people rely on their pharmacists and their pharmacy services to either count dispensing data from the pharmacy or have their consultant pharmacists help them track this data as well, which is a really good option. So I just wanted to take a second and just quick show of hands. How many of you in here do the actual tracking yourselves in your facility? All right, a lot. How many do it manually, either on Excel or on paper? Perfect, a lot. What about using your EHR like point click care? Okay, some. And then does anyone rely solely on the consultant pharmacist or their dispensing pharmacy? Nobody. Okay. And so just last month at Shea, Wisconsin sent out a survey of their nursing homes, and about 108 of them replied. And they asked kind of the same question over again, is like, how do you track your antibiotic use in your facility? And you can see pretty similarly, most people are using Excel or paper. And so I think this is still a very valid way to track antibiotic use. And so we wanted to update and share our tool with you today so that you can use potentially that to track as well. And then additionally, reporting. People are still really using Excel and paper, but a little bit more relying on their EHR to do some of the reporting piece of it. Another thing I really wanted to point out is, I'm sure you all know since you do it, but this takes a lot of time. Even in the smallest nursing homes under 58 beds, average is 8 hours a week spent on these tracking logs. And so I think this is something that if we can make it a little bit more efficient anywhere, this could potentially save you some time. And on the reporting side of things, again, even for smallest facilities under 50 beds, about 14 hours a month is spent on reporting. All right, so now we're going to transition into tracking, the tracking core element, and talk a little bit about what should be tracked. When I think about tracking antibiotics in long-term care, I always think of it in 3 buckets. First is the antibiotic use, second is antibiotic processes, and third is antibiotic outcomes. If you don't track all 3 of these different things in these buckets, it's going to be really, really hard to use your data to make any improvements when you report it out. We commonly hear at ASAP that people are doing a ton of work doing these logs, spending a ton of hours on tracking. They're very religiously reporting at every QAPI meeting, but they don't know what to do with the data. They're like, that's nice. These are numbers. They kind of check the box and move on. And what I find when I look at some of these logs and help people with this is that they're not tracking quite enough information or the right kind of information to do anything actionable with it. And so we'll talk about these 3 buckets a little bit further here. When I talk about antibiotic use, that means anything related to the antibiotic itself and what you're counting. So the 2 main things are antibiotic starts, the number of antibiotic starts, and then the days of antibiotic therapy. Some additional information you can track, again, to get the most helpful information for your reporting, is which drug is being prescribed, what is it being prescribed for, so your infection type, and then additionally the prescriber name. If you're in a facility that has outside prescribers, that most of you probably are, that can be helpful to track. And then where was that prescription written? I think can be very eye-opening to how antibiotics are being used in your facility. So all of those things have to do with the antibiotic prescription themselves. So you may have seen also on the last slide, when we talked about starts and days of therapy, that it was listed per 1,000 resident days. And so the reason that that is listed like that, we want to convert these numbers to a rate. This accounts for variation in how busy your nursing home is, and it allows you to compare yourself to other nursing homes that are maybe a different size than yours. So for example, if you started 100 antibiotics and you only had 1,000 resident days, but in another facility, they started 100 antibiotics that had 2,000 resident days, even though the 100 antibiotics are the same in both facilities, the one with only 1,000 beds used half as many antibiotics, if that makes sense. And so correcting it to this rate is really important, not only to compare yourself to other facilities, but for you to track over time as your census fluctuates in your facility. We also don't typically track and report all drugs. And so there are some that we do not usually include on the spreadsheet. And when we say this, I think mostly of drugs that aren't really systemically absorbed by the patient, or they don't play a big role in creating resistance. And so I think about antivirals like Tamiflu. So if you have a flu outbreak in your facility and you start 40 people on Tamiflu, your numbers would go through the roof for antibiotic starts and everything. So I typically advise to exclude those if possible. And then same with anything topical, whether it's on the skin or in the ears or the eyes. That typically doesn't play a huge role in promoting resistance, and so those can be omitted from your tracking log. A question we commonly get is, what about methenamine? Is that an antibiotic and should we count it? Because a lot of residents are on that prophylactically, and I recommend no. That's more of an antiseptic. I just heard at Shea a good kind of analogy as someone said it's like mouthwash for your bladder. So that's not technically an antibiotic, so we wouldn't count that. So now moving into that second bucket, we want to look at the process measures. So what happened in your facility when that antibiotic was ordered? So this is going to be things like, was that clinical assessment tool completed? And was it completed fully or partially or not at all? So I think Dr. Turan showed before the different types of SBARs. If you see that there is low compliance with that, you could additionally keep track of who is performing the SBARs to see if there are staff that need more education. And then additionally, we keep track of, was the load criteria met? Did you do a reassessment of the antibiotic therapy while it was still going and check in on the resident? Was your surveillance definition met from an infection control perspective? So these process measures are really more about like how the antibiotic was ordered and what happened while the resident was on it. The final bucket is the antibiotic outcome measures. And so I think of this as like, what are the consequences of that antibiotic therapy for our residents? Are you starting to see trends in resistance increasing? What about antibiotic associated adverse events or infection rates due to certain pathogens like C. diff or Candida auris or things like that? So I've listed on the slide here, and Dan will show you as well on the tracking logs. When I say pathogens of interest, these are the pathogens that we're referring to. And so they either have consequences because they are resistant or because they spread really easily from resident to resident from an infection prevention standpoint. You'll see when we talk about infection rates, this is actually usually reported in per 10,000 resident days because these are usually more rare. If you did per 1,000, the numbers would be very, very, very small, like 0.1. So just to make them make more sense, they're usually per 10,000 resident days. Additionally, tracking adverse drug events is really important, but this I would typically recommend you seek help from your consultant pharmacist to do. Antibiotics can have a whole lot of different side effects, as you can see from this big list here of all the antibiotics and all of their side effects. And this is something your pharmacist would be way more well-versed in, and they could evaluate for you. I think what's important is making sure, since you're evaluating the residents and your staff are evaluating the residents, to make sure you're documenting in their chart well enough so that the pharmacist can try to determine some of this stuff, like what was the timing of you giving the med and the reaction that potentially occurred and things like that. So that is another outcome that can be tracked. All right, so now I'm going to hand over to Dan. If you guys want to flip to pages 35 to 37 in your workbook so you can follow along, he is going to just go through their tracking tool that we created. And you can kind of see, just keep in the back of your mind, the 3 different buckets of things that are being tracked as he goes through that spreadsheet.
Thanks for having me. So I'm just so fortunate to be able to present to you this afternoon because they were assigned me one of the most exciting topics, I feel, because, you know, it's a Friday afternoon. Usually we're talking about Excel workbooks on Friday afternoons, you know, to get the blood flowing a little bit. So I was told I have 8 minutes for this demo, so I'll try to keep it under 30. So when we were planning for this updated tool, we looked at previous versions. We looked at other versions that other states and organizations had. We begged, borrowed, we stole from everywhere we could to try to simplify and provide the most useful tool that we could. We believe this one is easier to use. It provides better reporting. There's more tables, there's more graphs that really help summarize and visualize the data. Because as we know, it's difficult to manage what you can't measure. So as with any tool, the usefulness of this is going to be completely dependent upon the quality of data that you are putting into it. So with that, let's talk about some data entry. So we have a tab right here, the resident days present. This is entered, of course, at the end of the month when you know what those numbers look like. The next tab, this is the data tab. First off, there's no PII in here. I used a random name generator to create all of these fictitious names, but I just felt it looked odd having it blank. So looking at this sheet here, if you scroll up and you go over to each of those fields, it gives you kind of a brief description of what each is. And these colors up here, the salmon for classification and the green for history, those coincide with the colors in the data dictionary that is also available on the ASAP website. So let's go through and let's go to a blank line and let's enter a new record. So over here, we're going to start. The unit name, we'll call this one, this individual was in, oh no, I broke it. I know I broke it. Just kidding. Just kidding. So here, this person is in the north. And this individual, I like to use the last name first, followed by the first name. So this was Mr. Shoelaces. Oh, close enough. In room 102, because I know it's fun watching other people type. Great thrills. So this individual here had an upper respiratory. So there, you can either use the drop down here and pick it from the list that's available. So I'm going to pick that one there. Great. Okay, now we're going to just go through. I'll try to do this fast. So surveillance definition met. See, it's already populating based on the information that had already been entered. That is yes. Symptoms: cough, malaise, or something similar. So when was this symptom on date? So we'll say that was in June 1. No devices. Okay, now we're going to look, when was the test date? See, test date, we're going to say that was on June 2nd. Specimen source. And again, I'm using a type ahead, but it also works for the drop down. Again, trying to make it as fast as possible. Here. So skip over antibiotic name. So there's a lot of antibiotics. I don't know if you all are aware of that. So this one here, again, oftentimes they're misspelled. It creates lots of problems. So I like to use the drop down for that one. So that one is amoxicillin. So now we're getting into the provider name, because one of the metrics, one of the things to measure is how many antibiotics are prescribed by physician. So you can do a couple of different ways. You can enter the name, and again, I like to put last name first, makes it a little bit easier. So I could put Killjoy or Killjob. I'll do it, and it says here, enter a new provider name in the drop-down tab. What's that? So I could either say, yes, that's fine, and we're going to use this, and it'll enter it just like that. Or what I can do is I can go over to this drop down here and enter back over here. So this was, so entered a new physician provider right there. And now when I go back and I look at this drop down here, it's automatically available. And at least this way, you don't have to worry about the consistency. It's spelled the same way every single time. The move over here, next field, the origin. Long-term care. So I'm going to scroll over it a little bit here. So the start date for the antibiotic. Started the antibiotic on the 2nd. Now, it immediately populates or colors both of these cells because we don't have an ending date included yet. So this makes it a little easier for you to go back and find those where you're missing information. So once you enter the ending date for that, so let's say it was June 4th, they both blank out. If I accidentally entered a date that was before, so it's obviously wrong. Start date can't be after the end date. It also highlights that. So let's go back. Now it's at 4. Criteria met? No. No. Quickly complete this one. And then we have nearing the end, date symptoms resolved. This one would be, we'll say this one is June 7th. So, and then here you can add any comments that you want with that. So another thing I'm going to reference up here quick is, let's say these here are all the filter buttons. They're not sorting buttons, they're filter buttons. So if you wanted to see real quickly how all of the prescriptions that were provided by Dr. Green, select Dr. Green, and it narrows it all down so you can at least more easily and quickly consolidate all of that information. And then, of course, go back and select all to get everything. So, and that is valid for all of the columns that are out there. So once you've created all of this, some in my group here get annoyed because I oftentimes say, so what? So what? You're entering all of this data. How are you going to use it? What are you doing with it? Why do we collect it if we don't use it, if it's not required? So, and that's how we've gotten down to this number of fields, because these are the core ones that we want, that you need. So what that means then is when we go to the tables, all of this is automatically calculated. So total days of therapy, antibiotic starts by month. And if we scroll all the way down and not hit page down, because I'm using someone else's laptop, if we scroll down, there's all kinds of data and calculations that are available within this. You don't have to worry about messing anything up on this because it's locked. So you can see what the calculations look like. You can see what the formulas are, but if you try to delete or do any of that, it doesn't allow it. So you don't have to worry about messing anything up. Also, if you need to use any of this data, you can copy it, or you can actually use snippet type of process to copy it and then to paste it into presentations and the like. All of this data then is also represented in chart forms. So these are auto-generated. You don't have to do anything but provide accurate information on the data entry. And then all of this other information is automatically populated. And if you scroll over and you're like, hey, on this surveillance detection on this, you can scroll over and it'll actually provide you with what the percentages are if you don't want to go back and look at the table. But it just makes it a little more visually appealing to view what you've entered and the progress that you're making. Going down, all of these are auto-calculated, auto-populated as soon as you make the entry in that data sheet. And also, if you remember, this data sheet compared to what it had been, this one has all of the months. It's not separated for January and February and so on and so forth. Finally, coming back over to this tables again, I just wanted to make sure to reference. At the very bottom, the last table is powered a little bit differently on the antibiotics starts by provider by month. There is a thing here says Control plus Alt plus F5 to refresh this table. So you can see here the lists right now. If I hit Control Alt F5, it recalculates, at least it does on my laptop. It'll repopulate to include the latest doctor information, provider information. So we created this. We think it's better. We think it will be useful. We're happy to answer any questions. You may not have any right now, but download it, start using it. It's all local to your facility, so the data is not going anywhere else other than that. If you ever need to share data with corporate or the state or the like, you can just blank out all of the PII data, the individual names, maybe the providers, maybe the room numbers, and then you can share the remainder of that data without worrying about the PII data. We welcome your feedback, your questions. We'll be happy to answer them. And then some of the suggestions that you have might make it into the subsequent versions.
On the data part, do you know how much of the old one has each month? So we just stay on the same page and skip a line for the new one, or
You don't have to skip a line at all.
the data?
You don't have to you don't have to skip a line at all. Another thing I was going to mention, and again, don't have a mouse, so I'm trying to figure out how to do this really quickly. So let's say you have this entry, right? And Tyrone here had an antibiotic for one condition. He now has a different condition that requires a different antibiotic. So you can actually copy the entire line, go to the next line, and enter it there, and then just change the fields that you need, right? The antibiotic name, the date started, all of that. But at least here you don't have to re-enter everything if you don't want. Separate lines, but that's a great question.
You have that column B, or like if you have like additional antibiotics for the same infection.
No.
No.
Different question.
This is, yep. You want to take that? It's
So if they get started on 2 antibiotics, say for like pneumonia, they get started on 2 things, it will be 2 lines. What column V is antivirals and antifungals. So as I mentioned at the beginning on drugs we don't count, that's column V. It can still be helpful for you to keep track of like your Tamiflus and things like that. But column V does not get added into your total days of therapy. So you can still use it to, if you need to, from an infection control standpoint, to monitor the case. But it won't count towards your days of therapy.
But if you enter 2 lines with dates over on start and stop, those would add in twice, correct?
Correct.
So you may want to not do that. I don't know, because should we be including that twice? Because it's 1 resident, but 2 antibiotics?
You just not put in the illness.
That's what I would recommend. So you don't get 2 pneumonias counted, but yes, you would get, yeah. So thank you for that
So
clarification.
you would recommend that that basically is counted twice because it's 2 antibiotics?
Yes.
Okay,
Yep.
so it's-
Yep.
And the number antibiotics are prescribed by the doctor. Do we count how many residents they see? Because one doctor can have 30 residents, another one twice, and the number of antibiotics will get higher.
Yep.
Do we include the rate of the?
Yep. So the only thing that's actually not calculated by rate is the number of antibiotics prescribed by the prescriber. That's just a count because of that very reason. So the question was, in case you couldn't hear, prescribers see different numbers of residents within the facility. So not every prescriber sees every resident. So you can't use the rate across the board. So what we ended up doing on the tables page, sorry, is it's just a count of how many prescriptions they wrote here. So this is not a rate because they see different numbers of residents. But everything else above it is a rate for the facility. Great questions.
Clarify this for myself. Um, Just trying to clarify for my own sake here, if. Again, might have been already clear, but it was just a little bit not clear to me. If there is one diagnosis and two antibodies start, should we go with the same line or different lines?
You'll have to go in different lines because you can only put in one antibiotic. Like you can't put two in that box. It will not let you enter it. So you'll have to start a new line for that second antibiotic. But I would leave the fields blank for the infection. So put the resident's name. And then like, don't put pneumonia again, but just add the second antibiotic on that line.
If it's the same condition, then yes.
Yes, if it's the same condition with 2 or 3 antibiotics, just start a new line. And you can leave the
But
infection.
if there are different infections, like somebody is getting an antibiotic, hopefully not that, because you know, occasionally might. That somebody is really needing an antibiotic for pneumonia, but also have a serious infection or something like that, so you're probably giving a oral vancomycin to one person. You know, at the same time, something, so then you can actually write.
Then you can, yep.
You can write two different.
Yep.
So,
Yep. Just know it will count, so like the infection type, it will count, it is counting those here. So again, 2 antibiotics for the same thing, you would not, you just put the antibiotic on the second line. None of these fields are required, so you can leave them blank. It'll still function, the tables will still calculate, if some of the information is missing. Is that correct? Excel master?
Yeah, yes, except for the ones that are critical, like start date, end date, and the antibiotic.
Which is why those turn red, so.
So, you know how you may have a resident that have been started in May, but they invited this in until like the 12th of June. Did I put them in twice for May and June, or?
Nope.
Just once.
It'll just put. the-
Used to have to.
Yeah, you said.
Yeah, see, no.
So that gets rid of that step. So there you go, saving a step. So in case you guys couldn't hear, the question was if a resident gets put on an antibiotic in May and doesn't finish it until June. Prior to that, people put him on the May tab and the June tab. Now you don't have to do that since it's a running year. It'll count that one antibiotic start and then it will attribute the correct amount of days to May and to June. So Dan has built it to do that all for you, so you don't have to do any of that.
So
Yep.
the start will be different for the months. It'll start. one month,
Yes, yep.
You won't have that counted.
Yep, if it crosses over, it will count the start on the month the antibiotic was started, which is the best way to count things. Alex,
Forgive me if I missed it, but where do you input the resident information?
it is a separate tab here at the bottom. I can't find the mouse. Where is the
No,
mouse?
you got it, you're almost there.
Let's see. Yep, there. And the tables will not be able to calculate many of them without this information. And so this is a good troubleshooting piece. If your charts and tables are blank or not calculating, you're probably missing your resident days. That's your denominator for everything. So. And again, we are happy to get on a Zoom call with you guys, share the screen, walk through this in more detail. If you ever want to do it again in the future, if you're wanting to use it or have more questions, you can always email us as well. But I do have a few more slides, so we have to do the reporting part of it. So guess we'll keep going here to get done on time. What time is this done? 3:15?
Then you stop.
Yeah.
You have until 3:15.
Okay.
I just want to thank Dan for making this much more user. Thank you very much.
Yeah.
Thank you, but it can be better. I mean, it can be better, but we need your feedback. We need your feedback on what would make it better. These are things that we thought made it better, but you use it every day. So let us know.
Is Excel the only format you have for it, or can you do it in Smartsheet or some other database manager?
Right now, this is just an Excel.
Slides aren't moving. Oh, I had animations. Okay. Okay, so let's jump in just really quick in the last 10 minutes to the reporting piece of it. So when they say reporting, really the CDC recommends reporting this tracked data that we just looked at to the clinical providers at the facility and the nursing staff. So typically all of this data you're tracking and doing a lot of work to track, is available to a select few of people that work at your facility, usually in leadership. So we really encourage you to share some of these reports more broadly, especially if they have to do with an intervention or an action that you took and put in place, like to give that feedback to the staff, so they can see the changes that were made. It also helps with buy-in. I hear a lot of times that people have problems with a particular prescriber, a really hard time with them. And what I've learned is that sharing data can help, but it doesn't usually help immediately or right away. You may have to continue to share. They may need to see a year of data, a year and a half of data, and then they'll finally kind of start to come around and change practices. So I think having this more robust data can really help your case and make your struggles less, hopefully. So again, we've kind of covered this, but what to report. I think the two probably biggest metrics are the antibiotic starts and the days of therapy. Additionally, as if you're an IP, the rates of specific infections also is very important to be reported. What I like to report also to make it more meaningful, because again, we hear people religiously report these numbers meeting after meeting after meeting and nothing ever happens. Report the outliers. If you're tracking, are we meeting load criteria and you see only 5% of the time you're meeting that, that's what you should be reporting. So maybe instead of rotely reporting these same numbers month after month, meeting after meeting, look for anything that like draws your attention or looks off and see what your teammates in your committee have to say about it. So that's what I really focus on when I report data, is things that don't look quite right or things we want to take some action on. We also have a few templates available on our ASAP website, but I will say we just got this finished in the nick of time for the summit. So we're going to work on updating these as well with some of the new reporting things. But these are available if you need to use them. So Dan actually jumped the gun. He was supposed to show you the charts and tables now, but he was so excited I didn't want to stop him. So we can move right on from that. These next few slides. So now we've kind of covered tracking and reporting. But I want to sneak the action core element in there too, because I think that is the whole reason you're doing the tracking and reporting. So these next few slides are full credit to Alex in the audience. He gave a great presentation nationally on this last year. And so I want to leave you with this list. I won't go over them one by one, but again, when you're reporting data and you say, what do I do with it? Here's a list of things to do with it. So if you start to see these are things you can look for in your data and things you can do about them if you do find them. So just example for the very first one, if you have a low compliance with prescription documentation, so you're filling out your log and they never put on there what they're treating. Then you can kind of use your data to do that. So we have a few slides here you can take with you and look at, kind of try to apply them to your own data and see how that goes. Okay, lastly, I wanted to just touch briefly on benchmarking. I think this is kind of a new thing we're broaching in long-term care. This morning, I talked about the hospitals getting reports from us on how they are doing with their prescribing compared to other hospitals in the state of Nebraska. And this is something I want to make available for nursing homes too, because I think that is invaluable. When I said we had hospitals make big changes off those reports, like we were not kidding, they made big, big changes. And so having access to that kind of benchmark data to see how you're doing compared to others is really, really helpful. Because again, taking these numbers to your meetings every month and just saying, we prescribe 88 days of therapy per 1,000 resident days. Like, you don't really know what to do with it. So we want to help provide some benchmarking. There is some benchmarking out in the literature that's available from like the CDC got records from a pretty big group of nursing homes. So we at least have some idea of what a prescribing rate looks like in facilities. We also know things that like facilities with short stay residents have a way higher prescribing rate than those with longer stay residents, which makes sense. They see more people in and out the door. There's more chance that they'll get an antibiotic. So we do have that kind of data. We also have some national data showing trends in antibiotic use over time. So this is kind of similar to what you'll get out of your own tracking spreadsheet, and this is nationally. So we see some positive things here. A 50% decrease in the amount of fluoroquinolones used over the last 10 years is a huge win for me for long-term care. And so these are also good things we can get. Another thing that we can kind of learn from tracking some of this data is one of the big opportunities in stewardship is to look at duration of therapy. We just did an ICAP webinar on that, I think, March. So if you want to go watch that about durations of therapy and long-term care, that's out there. But I think we do have a lot of opportunity here. We get asked pretty commonly about prophylactic antibiotics, and you can see nationally about 20% of all antibiotic days of therapy in long-term care were from those very long courses of therapy. So about a fifth of all your antibiotic use can potentially be for prophylaxis. So that's what we know about benchmarking data in long-term care. That's it. Those 3 slides I just showed you. So what we embarked on, Dr. Ashraf's initiative here, is to try and create a way for Nebraska nursing homes to be able to compare to each other. And so we created this collaborative database earlier this year, and we currently have 39 facilities enrolled in it. And so if you would like to participate, it's pretty simple. There's a commitment letter you sign that just kind of says, you know, we will keep your data secure. It will not be shared with anyone but your own facility back to you, and kind of the things that you can expect from us. And then how it works on a monthly basis, on the first day of the month, you get an email with a link from us, and you have to put in 3 numbers: your resident census days, your antibiotic starts, and your days of therapy. That's it right now. That's where we're starting. It's not very much data, but it's just to get some sort of idea in benchmarking. And then we can feed back to you these reports. We just sent out the first round of the first quarter of these reports to those facilities that are participating. And the first page shows you your own data. So again, similar to what Dan's chart or tables and charts would show you. But then the second page shows you where others in the state are. It shows you where the high prescribers are, where the low prescribers are, the state average, and then where your facility falls. So again, not necessarily a measure of appropriateness or that you're doing anything wrong. It just gives you some idea. And I think if you cover more than one facility, you generally kind of know some of this data of who your higher and lower prescribers are. But again, I think this helps back up your, so they're not just your thoughts or your feelings, it's actual groups of nursing homes here in Nebraska that we can look at together. And so with that, I will end. If there are more questions, please do feel free to email either Dan or myself. We'll be happy to answer them. And I think that's all I have. Did you have anything else, Dan? You have a workbook. Oh, we have a workbook thing. We have 1 page. This one's not going to be too bad. So let's just do the 5 tracking ones. We can do by raise of hand. So first, a resident is prescribed azithromycin and amoxicillin for 5 days to treat pneumonia. What is the number of antibiotic starts that will be counted? 2. Perfect. Nailed it. A resident is switched from oral ciprofloxacin to IM ceftriaxone on day 3 of UTI treatment. How many antibiotic starts would you count for this resident? 2. Perfect. You guys are pros already. So we have a resident that began treatment with Levo for a suspected UTI, but after 1 day, they just went ahead and stopped it. She didn't have the symptoms. Does this still count as a start? Yes. A resident received 1 dose of the antibiotic at your facility before they went to the hospital. Do you count that as a start? Yes. And then if a resident is receiving UTI prophylaxis,